Good evening, everyone. Evening panelists, evening attendees. So welcome to our third day of our series. Today we are looking at cultural safety, advocacy, and autonomy. And we are joined by a lovely panel here today. Yeah, we've got a few people already here, so that's brilliant. So I'm Natasha, the managing director of the Women's Health and Maternal Wellbeing Initiative. I want to say thank you to everybody who's been attending for the last 2 days, and welcome to people who maybe are here for the first time today. I'd like to introduce my co-host, Agnes. And Agnes, you can introduce the rest of the panel.
Great. Hi, everybody. My name is Agnes Ajipong. I wear a number of different hats, most notably as head of engagement at a national charity called Best Beginnings. And I'm also Maternity Voices Partnership Chair for Guy's and St. Thomas Hospital. I'm delighted to have two esteemed guests with me here today, and I'll let them do the honours of introducing themselves first. So Elsie, would you like to go first, please?
Thank you, Agnes and Natasha, and good evening, everyone, including Anna. So I'm Elsie Gayle. I am a practicing midwife, and I'm also a registered nurse, an activist, mother, wife. Yeah. Very focused on solutions in maternity services now, particularly for women who have the worst outcomes of all and their families. And what the Embrace is telling us is the women of African descent. So that's kind of where my focus is in terms of solutions. Thank you.
Thank you, Elsie.
Hi, I'm Anna.
Thank you. Thank you, Natasha and Agnes, for having us here this evening, and thank you to everyone who's attending. So my name is Anna Horn, and I'm a doula and a breastfeeding counselor, and also a doctoral student. So like lots of people here, I wear lots of different hats. And I'm particularly interested as a researcher in decolonization, cultural safety, and obstetric racism. And so that's kind of the thread of my research. And like Elsie, very much interested in the experiences of Black women.
Thank you, Anna. Anna, you have underplayed some of your special powers. But thank you. Thank you for sharing what you've done, what you're doing at the moment as well. And I know you've done some work in breastfeeding, so just wanted to mention that as well. So I'm going to hand over to you ladies. Who wants to go first? And you can keep yourself off mute as well, so you can come in where you want to. Who would like to go first?
Anna, do you want to?
Shall I kick it off then?
Yeah, go ahead.
All right. Well, I've been very honored to attend all of the events so far. I've been listening, and I feel like there's a thread in the conversation that links with cultural safety. I know tonight we're talking about cultural safety and autonomy, and I feel like cultural safety can kind of be an umbrella for all of those kind of subtopics. And there were a few things mentioned in earlier sessions that made me really think about how that can tie into cultural safety from a service user perspective. So I'm really interested in the lived experiences of in pregnancy, in birth, and in parenthood. And something that other participants mentioned in the series is in terms of decision making, that your decisions need, you have to have the evidence, pros and cons of each procedure, and then make a decision based on the facts presented to you, but also in line with your own personal values and beliefs. And I think that's where cultural safety really has its place, because, you know, it's important to understand where people are coming from when they make their decisions and why they feel a certain way. And why certain decisions are more important to them, or why they shy away from certain procedures. It made me think about the term embodiment, which came up quite a bit, and how we experience the world through our bodies. And that reminded me of trauma. That was last night's topic, and how our bodies remember trauma, and even ancestral trauma. I know a conversation that Natasha and Elsie and I had earlier about you know, women who would rather, and Elsie, I don't know if you want to speak about this, but women who make very difficult choices, and maybe healthcare professionals might see them as risky, but sometimes women would rather choose this alternative decision because they would rather, you know, that's what's most important to them than to go into the hospital, and to be surrounded by an environment that perhaps trigger probably things that you're not even consciously aware of, but there's an ancestral, cultural stigma and feeling around it, that I think maybe people that I think is much deeper than people realize, and that it becomes really important to people when they're making their decisions about induction or where they want to give birth and that kind of thing.
I like the point.
I just got a quick point, Agnes, that I'd like to add to Anna's, and also a question. I like the link that you made from yesterday's webinar. We focused on decision making, and then the kind of repercussions or the long-term effects of, like, I guess, in a sense, we talked about embodied decision making, but there's also kind of like a culturally safe decision making process that you're describing here as well. So I'd like you to also just explain for me, Anna, like, could you simplify what is cultural safety? Because we hear a lot of people using it. There's quite a few different perspectives, even from a kind of research position. We hear it, it's been used in the NHS before, but I don't think you're talking about the same thing. So could you explain what you're referring to when you're saying cultural safety?
Yeah, thank you, Natasha. That's a really good question. I think, you know, sometimes we hear these buzzwords buzzing around and we don't really understand what it means. So people might use cultural competency, cultural safety, cultural awareness, and they may use them interchangeably, but the philosophy and the kind of theory behind the concepts, some of them are shared and some of them are very quite different. And at the moment, cultural safety has really been acknowledged and recognized as a part of practice that takes into account kind of the socio-historical context that people come from. So it started in New Zealand with Maori nurses who said, look, you know, we need to take our history into account when we're caring for people. We need to be reflective as, I'm not a healthcare provider, but as healthcare providers, be reflective of our own biases, our own experiences. Because I think what other concepts like cultural competency, it kind of removes the practitioner and sets things up like you can become competent in someone's culture. And I mean, that's not possible. You know, there's, you know, people aren't a monolith. There's so many variations in our experiences and our beliefs and what we want and what we need.
And they might make assumptions as well about someone just based on their skin color. I think Marley mentioned something on the first day that people made assumptions about her ethnicity. Yeah. She was noted down as a white woman, and her daughter was noted down in their records as a child of African descent.
Yeah.
You know, but her children obviously are products of her and her husband, they're mixed as well. So yeah, people can make assumptions about either culture or I guess, yeah, your culture based on like what you look like.
Exactly. And make assumptions about what kind of care you need and what you might like and what you might not like. And you know, I remember reading articles about some healthcare professionals making assumptions about Muslim women, that they might not want a male healthcare professional, or they might not want to have care in groups because they might not want to show their bodies to everyone. That's an assumption that people make, trying to be considerate, but it's really, you know, you're not competent in that culture. I think cultural safety is about looking at the individual in front of you, being aware of the social cultural context which shapes people's lives, being reflective in your own practice. I think those are the key things that make it different to some of the previous kind of cultural sensitivity kind of tools that we tend to use.
Okay, so I just want to broaden that a little bit.
Right.
So I met this concept of cultural safety when I registered myself as a New Zealand midwife. And it led me then, I'm not an academic, but it led me then to research the concept and went back to the root of how this was developed. And as you say, it came out of the Maori community, wherein a Maori nurse, Iri Hapeti Ramsden, she found, well, I guess she was, you know, really researching why it was that the Maori community were having such poor outcomes within the usual healthcare systems. And she set about then to do a piece of, it's the most readable research PhD I've ever, you know, encountered. I read it from cover to cover. And what I took out of it was that there is something about a power imbalance that is so embedded into healthcare, but it actually goes beyond healthcare. It sits within society. And to be culturally safe, you actually have to recognize all of those things. I mean, really complex, but you have to be able to recognize all of those things, especially the power imbalance, and actually to be culturally safe, or to be a culturally safe organization, because it can apply to an individual, but it can also apply to organizations and society in general. You have to recognize those things, recognize within yourself a bias. And actually, what I got was that if it, as a healthcare professional, you are unable to work with somebody in this way to redress the power balance, having recognized that, you must step away and allow somebody else to give that care, because you are developing a therapeutic relationship. And if you can't do that, you're actually going to damage the person. So I've actually had to use that in my own family life to achieve a healthcare pathway that was culturally safe. So I just want to read a couple of things that I picked out of this piece of research. It requires individuals and systems to examine themselves and the power relations which affect care delivery. In particular, the effects on the healthcare system of inequalities in power between groups in society, and to address them. They need to examine their own realities and the attitudes they bring to each new person they encounter in their practice. And they need to evaluate the historical, political, and social processes that they have on the health of all people. It is an environment which is safe for people, where there is no assault, no challenge or denial of their identity, of who they are and what they need. It's about shared respect, shared meaning, shared knowledge and experience of learning together with dignity and truly listening. And then opposed to that is unsafe cultural practice is any action that diminishes, demeans, or disempowers the cultural identity and well-being of an individual or a group. And for me, that is like my benchmark. I couple that with informed consent, which is something that you had actually you mentioned. And some of those things are actually based in law, in terms of the Montgomery judgment. That was a profound piece of legislation that overturned such a lot in healthcare in this country. And the evidence base that we're supposed to be using is all of the types of research that there is, including the randomized controlled trials, but also we have to apply the needs and the values of people, and that is embedded into NHS policy, but also the clinical experience of the clinician that is actually delivering the care. So there are times when I know that some things are outside of my reach, and then I have to refer on to a suitable clinician beyond that. And I think this is one of the reasons why continuity of care model is so profound, because it can actually embody all of those things, really. But you can still have continuity of care from somebody who is racist or who has a different lens. They don't necessarily have to be racist outright. They can have a different lens and not really understand the damage that they're doing to people. So, I think these things are really, really important. But on the other hand, which healthcare professional in this day and age has the time to even look into these things that we're talking about, and then the power or the autonomy to actually use?
So this was going to be my next question. Oh, goodness, go ahead, because you had something before.
Yeah, no, I think you both raised some really good points, and it kind of leads on to what I was actually going to say earlier. You both kind of touched on it, but I just wanted to kind of reframe it and reaffirm it, because what I'm hearing is kind of like the way that we currently deliver maternity care at the moment is very clinical, and sometimes that's weighed as being the most kind of important measure, when actually, if we're looking at cultural safety, something, when we're looking at cultural safety, it's on par. Like they're all, same different matrices. So somebody, a doctor or a professional with the best intentions may be giving you that advice, but they're giving it to you purely through a clinical lens without understanding that, the cultural aspect, that there could be a particular reason as to why a woman needs to give birth at home, for example, of course, if as long as she can. And it might be a particular reason which is really important to her well-being, her mental health, all the other aspects that make you a being. We're not just robots that you just take us in and have our MOT and kind of put us on our way, right? We're humans, so there's so much more that makes up the very fibers. So that's what it sounded like. Elsie, so you're looking a bit, could you expand just there's a new term for me and I find it really powerful.
Wait, which term? Cultural safety?
No, cultural safety is a new term for me in the way that you've explained it with the whole Maori and so forth. But that's the energy I'm getting, and I just want you to kind of elaborate on that a bit more.
And that is the root. That is the root. And, like other terms like intersectionality, and Natasha and I were having a discussion about that. Things get, and misogynoir and things like that, they just get taken by, somebody hears them. Oh, it sounds like this. So they use them in ways that actually are not helpful to the root of what we're trying to address. So going back now to the root, let's go back to the root of birth. What is birth? For me, as a midwife, I was taught, and we are supposed to be taught, birth is a physiological process in the main. It's not a clinical process. We're looking at people mentally, physically, emotionally, all round. It's an all-round process. And what actually, I had to reflect on it many years after. So I did my nurse training first. I did it on the South Coast, where there was loads of old women being looked after. And what really got to me sometimes, like, why are they talking about the baby that they lost and they never saw, and it's haunting them forever? And it's only when I came to do my midwifery and the understanding of the emotional processes that women go through, I'm thinking, my God, clearly something went wrong at that birth. They were probably told not to see the baby. It was best if they didn't see the baby who had died of stillbirth or whatever. And it haunted them until they were in their 90s. And, you know, so if it is that we want people to birth well and live well, interact with it, nurture their newborns, maintain a good family life and so on, for God's sake, then surely we have to, I mean, in my head anyway, we have to help people to journey through what it is they're going through, whatever it is, and make their decisions themselves.
Yeah.
If I can just add to that, Elsie, you know, I completely agree with that. I think in maternity care in general, it's, you know, I think from a clinical perspective, you might see it as a particular period of pregnancy and birth. And once you have that baby, then you're discharged. But how you care for people in their pregnancy, how you show up for them in their birth has a lifetime impact. You may see hundreds of babies, but for that person who's given birth, or didn't go home with their baby, or, you know, that will stay with them forever. You know, many of us here are mothers, and, you know, you talk about maybe to your mother-in-law or your mother or your grandmother, and they talk about births that they had 30, 40 years ago, and it still brings up emotion for them. So I feel like, you know, when, you know, I like that you said, Agnes, that, you know, it's all of this is on par with the clinical. I think we kind of get wrapped up when we talk about evidence-based practice, about, you know, what does the quantitative data say? What are the numbers? And we forget the human experience. Don't think of it as important. You know, it's more than just surviving the birth.
I think the profound.
Sorry, no, I was just going to say, just to add to what Anna is saying, the other thing that, you know, that struck me when I heard her say it, Professor Sue Down talked about that evidence at the population level sometimes gets distorted at the individual level. So how do we reconcile those things as well? You know, it's we have to be so careful. And as midwives, okay, I was trained in the time when we didn't need a degree. We had no academic, you know, particularly academic training, although there were some, you know, some efforts being put into that. Nowadays, midwives are being, they're having a university education, and many of them go on to do masters and PhDs and so on. So they're actually able to navigate the use of research in ways that people like myself hadn't been able to do. But at the end of the day, we are all supposed to be using research in our work, interacting with our clients or patients or whatever you choose to call women or persons who are giving birth. And I think it's really, really important that we understand. So doctors have a higher degree of that sort of learning, that approach to healthcare working. But we need to be able to utilize research. We need to be able to be critical of research. We need to be able to use it and to understand the flaws and sometimes the fraudulent ways in which research is used in maternity care, because we're a different entity. We're not just technological. We use technology to support us, but we need the whole, but we need a balanced approach. Otherwise, there's a whole lot of trauma going on, you know.
So one of my thoughts around this is just kind of what you were talking about, Elsie, like you talk about these different kind of elements that need to come together. So one of the things I know that about hospital safety is that there is a aspect that needs to be advocacy, that it's everybody's responsibility. So it isn't just down to, for example, midwives to deliver culturally safe care, but actually that the wider organizations, systems need to recognize these historic legacies, the kind of where inequality sits. And even you could go so I say like employers as well, like recognizing their role, because if we're thinking about health inequalities, particularly when it comes to Black women's health, you know, Jenny Douglas has some brilliant work around this, and she was, I remember watching something and she was saying that Black women are more likely to experience, I believe, I hope I got this right, but a stroke after a stressful event at work. So when you're kind of looking at health inequalities, there's a wider responsibility that needs to play into women's health, but also maternal health. So I think that that's something that people need to think about. A lot of the time you think, well, it's not my problem. It's not my problem. But we don't live like in silos, like we're all connected. And the burden of poor health will hit us all at some point. An example, you know, you could argue is it's part of the reasons why there are shortages in places, because people are burnt out, they're not treated well, it affects their health and their well-being. So it does impact us as a society. And so we need to actually place a value on individuals. We need to place a value on human bodies and human agents as well.
But that's a huge, that's part of a huge complex situation, because there's a lot of gender stuff going on in there as well. You know, where do we start? And really, where do we start to make things better?
I think this is like the heart of like, I remember the Embrace research. I can't remember her name, it's gone out of my mind for a moment. But the heart of her work, where she talks about kind of like heart disease not being recognized.
Marion Knight.
Marion, that's it, thank you. Saying like it's not recognized, you know, in women. And so, you know, health, you could argue, is kind of gendered in the sense that like the research that goes into women's health is not where it needs to be today. But the care and the standards that need to be met are not being met. So we need, again, for the government, for agencies to value women, not just economically, but just for who we are and what we, you know, I hate to say what we bring, because I feel like there's this emphasis that you have to be productive to be valued. Oh. But you should just be valued.
But Natasha, and this is something, you know, when I was doing Aquinatal as part of the development of our practice with the women, I'd have to remind them, girls, we birth the world. That's what we do. You know, we have to recognize, even if nobody else recognizes that, we have to do it for ourselves, you know. This is who we are.
That makes that point makes me think about what's so empowering about cultural safety is that no one gets to decide if a practice, if that's a healthcare practice or a practice within an organization is culturally safe, but the individual. So this is nothing that, you know, people can go around with the tick boxes and say, oh, we've you know, implemented this, this, and this, and now our organization is culturally safe, or now our care is culturally safe. You have to go back to the people and let them decide if it's culturally safe or not.
Yeah. And I think to add to that, I really like it. So I'm going back to the culturally safety point, Elsie, that you mentioned. It's when I've heard cultural safety, and I've heard it of course a million times, it's very much on a surface level. It's not about the root, you know, the bit about midwives actually stepping away if you feel that that aspect of it has been lost in translation, you know. So even like today when I heard you explaining the roots of where it came from and the practices and so forth, that's why it was so profound for me as well. Like I hear this term all the time and it is not in that way. It's like it's been really whitewashed and repackaged. And actually in the way that it's been repackaged, I feel like it actually does more harm, because it's people saying a lot of things but actually not saying anything or doing anything at all. So it's how do we get back to the root of what cultural safety is, you know, that kind of self-awareness of self, you know, in those environments, and being able to have that discernment to say, I need to be here, or actually, you know I don't have the capacity or the emotional intelligence or whatever it is to deal with the situation now. You know, I'm not a racist or whatever it is, what people want to think or whatever, but I actually know, you know how it is now. So the people hear the racist word, whatever it is, I don't know how to give this woman the care that she needs, and I can see that. So I'm going to step out and see if I can find somebody else within my team to be able to support. And the funny thing is that you would do that in any other area. If I'm working now with my role and I find that there's too much spreadsheet stuff going on, I know to say, you know what, this is a bit out of my capacity. I don't like these, you know, the spreadsheet is a bit complicated. I'm going to go and find somebody within the organization who can support, because I feel that they will be better placed to handle this. We do it when it comes to other aspects. But actually, I feel like maybe because we're dealing with humans and people are so worried about how they're seen within themselves, you know, that kind of centering self in it, people don't do the same thing within such a vital scenario, which is, you know, you're dealing with human beings in a life and death situation, to say, actually, in this particular person, because we're all individuals, actually, I think one of my colleagues would be best placed to give this person the whole well-rounded physiological, you know, spirit, mind, heart, and the physical support that they need. And I think that's really lacking.
The other thing that is lacking is the fact that, I'm so sorry.
That's okay.
Well, it's really what Anna was saying about the person to decide is the client, the patient. They're the ones to decide. And I think it is really important that the two sides are able to come together. But yes, sorry, Anna, you were going to say.
That's all right. I mean, that was you know, you raised a lot of important things, both Elsie and Agnes, and it just made me think particularly about kind of the superficial use of terms like cultural safety. And it, you know, it makes me realize that you know, cultural safety is not just for people of color. It's not just something that you apply to your Black and brown patients and clients. Everyone, it's a culture of safety, of seeing people as individuals, as recognizing, like we said, the historical context that shapes people's lives, recognizing their own beliefs and what's valuable for them. So it's not just something for Black people. And I think, Agnes, when having that strength to be able to say, this is perhaps I'm not the best person for you, instead of taking this approach as, you know, I'm medically trained and I know the evidence and I'm telling you what's best for you. You have to be self-reflective, and you have to see, okay, well, maybe, you know, this relationship isn't gonna, you know, is not good for this person, so I need to step away. It takes self-reflection to be able to do that.
And that's the next thing I wanted to go on to, the two things that I know that we've kind of discussed before in the past, which is reflexivity. So I hear that some people might not be suitable, but also there's an important aspect of learning. And what they can learn and take away. So I'm not saying we use people's trauma and life experience for our own lessons, but there is an important fact where somebody realizes, oh, I've got a blind spot, you know, or I haven't considered this. And I think there was a story that I learned from Elsie a while ago, where you said that there was a healthcare professional that remembered, I think there was a woman that had a heart condition, and they were trying to send her home. And then this particular doctor remembered that they had heard that Black people have a higher rate of mortality because they're ignored when it comes to like heart problems. And then she insisted that this woman was given more further examination, even though they wanted to send her home. And then it was a good job they did, because if she had been sent home, she would have died. So there is something that, you know, within a cultural safety, that's not just about kind of like throwing your hands up and saying, oh, I can't deal with this and I'm not good enough, but actually challenging yourself to say, let me stop for a minute. This person is the expert in their body. They are expert in their own lived experience. Let me just listen. Let me try to understand and let them explain what's going on for them, what's happening for them right now. And then within that, recognizing, which is another word I've learned from Anna, their own positionality. So Anna, I want to hand that over to you.
Hold on. For all of us that are new to the word, could you repeat that and slow it down? Because, you know.
Positionality.
Let's write that
Anna
down.
is going to break this down for us, because I think this is one of the most powerful tools for us to really understand cultural safety, and Anna is an excellent teacher.
Oh gosh, now I'm on the spot. Well, I kind of approach, I found anthropological tools that we use in research, like positionality and reflexivity, fits quite well when trying to build a culturally safe practice, because your positionality is everything that kind of makes you who you are, all of those blocks. So for example, for me, it's, you know, I'm a woman, I'm a Black woman, I'm a mother, I'm you know, college educated, I'm from America, you know, all of these things that shape my worldview and how I see things. And there are things that I might know about because of my positionality, and then as we said before, there are things I have blind spots about. You know, I don't have the experiences of, you know, perhaps being in a same-sex relationship, or being transgender, or perhaps being, you know, being someone, I'm in England, I speak English as my first language. I don't have those kinds of experiences. And perhaps that can be a blind spot for me, but being aware of your positionality can help you understand power dynamics between you and, you know, the person sitting in front of you. And what
even as a Black person, right, Anna? So
absolutely.
So cultural safety isn't about like the white practitioner, the Black patient, or the Asian patient. It's about, as you said, that those building blocks. But even as a Black person, thinking, oh,
but can I say something? I think it's beyond even as a Black person, because it's only in the Western world that we are Black, right? Like I'm Black British Ghanaian, and my kid's father is, you know, Black British Tanzanian, East African, and I've been to Ghana, and you can't get more different. Like, I believe East Africans have got more in common with Irish people than Ghanaian have with, like, completely different, right? And when I I've lived in Tanzania, I've been to Tanzania, and when I'm there, I'm literally the most foreign person, you know. Ghanaians in comparison to Nigerians are the quiet ones, but obviously in East Africa, we're the loud ones, right? So I'm like completely different. It's a foreign world. It's understanding that everybody coming from all these different backgrounds come to England, yeah. In England, we're Black now, England, but we're not Black in Africa, right? And I want to explain that just for anybody that's on the line here, is we're more where we're from, our country, you know, what we're representing, because everybody's Black. Everybody there is Black. Yeah. So, you know, there's no standout there. So when we come to England, and, you know, there's the Caribbean midwife, there's a Tanzanian midwife, there's a Kenyan midwife, there's a Nigerian midwife, there's a Ghanaian midwife, there's a South African midwife, there's a Zimbabwean midwife, and so forth. And we're expecting that because everybody's Black within the Western world, we've all got the same lived experience. Then there is those that are directly from the motherland, and then those that are also first or second generation, let's say like myself, all completely different experiences. And I think actually one of the biggest harms that we do here within the maternity care, in general, but then also, in general, is feel that Black is a monolithic race without diversity and so forth, even within that, you know. So yeah, I just want to say, when we say even if, I think it's actually very important, because sometimes that can be a barrier for us as Black people to also deal with and iron out some of the things that we need to iron out as well within our maternity care experiences.
that really speaks, you know, that's so beautifully put, you know, because even I'm a Black American, and you know, that sometimes really confuses people. And I've been to, you know, register at the GP, and you know, in America, you would say African American, and people know that you mean that you're descendant of Africans many generations ago. And I come here and I quickly learned, okay, I can't use that term because it confuses people. Because when I go and say I'm African American, some of the responses I get like, oh, so are you Black and white? No. Or the next question. And even other Black people have asked me, but where's your mother from? Where's your, and what about your grandmother? America, like we've been in America for so yeah. So to assume that that just having a Black person in front of you will solve the problem, I think is very simplifying the complex experiences that Black people experience and live and have. And I think, as we said before, if you throw your hands up and say, you know, I can't do this. You know, there's a difference between knowing when you need to step out and knowing when you should challenge yourself and learn. And I think it's easy to take kind of the easy road sometimes and say, I can't do this, you know, I'm white or whatever. And then you push all of that onto your colleagues of color that then have to take it on because they're expected to know the nuance and understand it. But we all have a responsibility to understand that those social differences.
So one of the things I have noticed, certainly having had to choose to bring up children and have them educated here in this country, is the fact that the education system does not allow for a broad spectrum of learning. It's very narrow. And so, well, for that reason, we chose an alternative system of education for our children. And then they were able to travel. So they got the breadth of the world, so to speak. But a huge part of people's lack of understanding, I believe, is because of the education system here. It is very empire-based, it is into Britishness, although nobody can define what Britishness is about, right? And it is it doesn't teach people to think for themselves. It is very much, you know, learning by rote and just being taught to pass exams and things like that. So it's for me anyway, it really is not helpful for that sort of education when you're trying to deal with a complex problem like, and let us call it as it is, systems of oppression like racism, where women, young women are preferred over older women. Women are not preferred or held in as high esteem as men, and people who are poor are at the bottom of the pile. You know, so it's really an enormous issue to deal with, even if you have cultural safety in your toolkit.
I think this is where, like, Elsie, that interdisciplinary education within healthcare needs to come in. Because I'm quite surprised about the lack of interdisciplinary learning that there is. And I think there's only been an appreciation of it in the last couple of years with COVID and with the George Floyd situation and the resurgence of like the kind of focus on race and things like that. And so for me, like, we don't kind of take other perspectives and apply them to healthcare. So when you're talking about like the poor, the gender, these are all things that historically have been issues. You know, you've had like the suffragette movement, we've had like the shift from feudalism into the industrial, you know, phases. So we've got all of this history, but that doesn't play a part of many healthcare professionals' education. It's kind of like as far as I'm aware, they can choose to do modules that maybe touch on certain elements of inequalities or health equity. So for me, that this means it, and actually we need to kind of move away from just only thinking about health in a kind of quite restrictive way. I feel like that it is quite restrictive because I don't see this discussion reflected in policy or strategy, and people think that it's so abstract, like you can't, how are you going to put this in practice? So my question to you, Anna and Elsie, how are we going to put this in practice?
Well, I want to correct you actually, Natasha, because if you look at the NHS policies, they have some of the best policies in the world. But where are they? Sitting on people's shelves.
Yeah, well,
some of them flung down in dusty old basements and so. So it is not that we don't have the knowledge and the understanding, the baseline understanding. There is a lack of the ability to bring policy into practice. And I go back as far as looking at racism. The NHS understands what systems of oppression are and what they do and how they impact people who have melanin, extra melanin. They understand it. And it was some years ago that the mental health system put a whole lot of money, time, effort, resources into trying to do something to improve the mental health system, in particular for Black men who had the worst outcomes of all. And those policies just faded away. All the people who they brought in just faded away into nothingness. They brought people from the States. Joy DeGruy-Leary is one such person who looked at the intergenerational damage through mental health issues. You know, so they had all these things at their fingertips, but until today, young Black men are still dying through poor support in the mental health system. So it is a lack of, you go never look for them policies. Changing childbirth is one thing. Look how long ago changing childbirth was. Julia Cumberledge prepared changing childbirth. And now we have better births. Same sort of thing.
But do you think it's just, sometimes I feel, this is just a personal reflection, where sometimes I feel that some of these initiatives and things, it's like chasing the new shiny thing. You know, it's chasing, and you know, I feel, and the reason why I'm very unapologetic about centering the lives and experiences of Black pregnant women and families and focusing on maternity care, because I feel like even if I spend the rest of my life working and advocating and researching in this field, will it take that long to see some progress? I think so. I think this is a lifetime of my investment in working in this field to improve it. And sometimes I feel like initiatives, depending on who's in power, depending on what the agenda is, it will change. It might be maternal mental health this week. Next week, we're worried about the Black maternal crisis, and the resources just shift and change, and you're not able to see these long-term, meaningful, multi-generational kind of impacts in the it doesn't feel that way, because I know that you, and this is, again, it's more of a personal reflection, because you can see the graphs and the charts, and maybe you see maternal mortality going down, and people say this is proof. But when you talk to your mother and you talk to your grandmother and you go back and read slave narratives, the stories are the same.
Yeah.
Yes, I know. But sorry.
Because it's like, I did a lot of work on like perinatal reforms, like looking at the work of Sasha Turner, and it's like, I know it's completely kind of different in a kind of historical sense, but it was like, oh, things were put in place, you know, that was meant to kind of like lift the load, right? And then like in a kind of historical, metaphorical sense, it's like, you know, there's things that are put in or suggested that's going to apparently be part of the solution, and it's, you know, not quite significant enough to make a difference.
You know, one of the things that, well, I see the same things that you guys are seeing, you know, ever since Caroline Flint. I mean, I can talk about this country because I've been a midwife in this country. Caroline Flint in, I forget which year it was now, in the 80s, let's say. She did a randomized control trial, a full-blown thing. She wrote it up. It was called the Kim scheme. It was in the NHS. Where is that now? And several iterations of that by different people.
Yeah, but I think it's a, sorry, I thought you
go ahead. Yeah.
I don't want to interrupt. No, I was saying that the point that Anna and yourself has kind of made is it's not going to change until society changes. Like, that's really what it is. You know, what we're seeing in maternity care, it's a mirror to society. And I use this example, which, as I said, you know, RIP and, you know, God bless her soul to Sarah Everard. But when you look at the new kind of recommendations that have come out of that from the police commissioner, she says that, you know, women, if you have any fear and you're by yourself and get stopped by a policeman, you can call down a bus or you can run. I know that's not for me, because I know as a Black woman, if the police stops me and I run, right? Yeah, that's a different story. Yeah, if I run, anything that happens to me after my foot hits the ground and I run, Daily Mail and everyone's going to say, but why is she running from the police? You know, if you run from the police, that's the result. And no one feels sympathy for me. But I'm just being honest, and this is nothing to what's happened to everyone is awful, and I really want to stress that, you know, the tension should be there, as it should be with all women from all different backgrounds that have been brutalised. But I know that advice that has been given out right now by the chief police officer, Cressida Dick, I know that advice is not for somebody that looks like me. We all know this, right? Mm-hmm. Now, the point to say is that until advice like that is for somebody like me, that's when I know that society has changed with what you're saying, Anna, because the work you wouldn't need to then be advocating and for, particularly for Black women, because we would all be seen in all the different spheres of society. Right. As equals and as, do you know what I mean? So the advice of listening to women would be just for women. The advice, if you're fearful for the police, would be for all different types. Like, it would be for all types. But until it's not like that, then we're going to continue to be in these problems, because it's just all the people that we're dealing with, you know, when we do have these biases and these traumas, it's a reflection of the society. They're going home to their spouses. That could be a teacher, one could be a nurse, another one could be a teacher, another one could be a police officer, the other person could be the person working in the post office. Do you know what I mean? They're having the conversations around the table. They're having so until that starts to change, where you know, what can we do about that?
Yeah. Well, you see, one of the things that I clearly remember Sheila Kitzinger saying is that women have to take back birth. That is what will make it change. And she was an anthropologist.
But I think
what I do, you know, sorry, Natasha, I just want to finish that. What I have started to see, which freaks me out no end, is that women are stepping away from NHS services to birth by themselves. And you know, I speak to a lot of these women. We have normally a Tuesday evening group that come together, Black women who come together for information, for support, and so on. And I get invited on as a midwife to have discussions with them. And generally speaking, I am trying to find ways through the NHS pathway to help them. But a lot of these women have begun to birth by themselves. And I'm thinking, like, how the heck do you manage that? And one woman said to me, I mean, honestly, I was just so shocked. I didn't know what to say, but I couldn't help her because I have no insurance for birth as a private midwife, or as an independent midwife, sorry. And what she said was, I'm going to have to be unconscious for them to take me out of this house because I am not going in to the hospital. And that was as a result of some severe trauma she'd experienced the previous time, including being referred to social services. You know, it really bothers me, really.
You know, I see some of I love hearing Elsie speak. I could just listen all day. But you have so much wisdom and knowledge to share. But I kind of think there are ways that women, and particularly Black women, are resisting these oppressive systems like maternity care, if it's, you know, seeking independent midwifery, or if it's choosing to birth alone. They're resisting the, you know, the idea that I would rather do this, which is considered, you know, risky, maybe birthing alone, than going into a hospital. You know, I'd rather do that than go into this environment where I don't feel safe, where I'm triggered and traumatized. And I think we need to, you know, we need to recognize that. And you're right, Agnes, when you say that, you know, maternity care is a microcosm of our wider society. And, you know, I always try to see the light in things. And I feel like, you know, birth, you know, is the center of the community. Like you said, Elsie, we birth the world. And why not let maternity care and services and birth and women be an example of what we're aiming for in wider society? You know, let's dismantle the oppression. Let's listen to women. Let's uplift marginalized voices. Let's practice culturally safe care. And maybe the world will catch on, right? Because it's literally starting in our wombs. So, you know, this movement is starting, you know, with birth, to exemplify the change and the social change that we want to see, you know, in the wider society. And there's something else that I find particularly empowering about cultural safety, is that it's a strength-based approach. It, you know, it looks at your culture as a strength, and not necessarily as, you know, blaming people for their conditions and blaming women. Well, you know, if you had listened to us, then your baby wouldn't have died. Or if you weren't so fat, if you didn't have diabetes, if you didn't have high blood pressure, if you didn't, you know, let's, you know, moving away from that deficient place of let me fix you, you know, and this is why you need all these tools and instruments to facilitate your birth, and rather come from, you know, a strength-based approach, acknowledging that wisdom and the power that people carry with them. If it's okay, if I could just speak again, just from like a personal perspective of, you know, I'm 30 weeks pregnant tomorrow.
Wow.
And, yeah, it's come along quickly, hasn't it? And have had a diagnosis of gestational diabetes. And I've been reflecting on it a lot. And, you know, my mother had diabetes and needed to use insulin. My grandmother had diabetes and had to have a leg amputated because of it. And so when I got that diagnosis, I realized now I wasn't grieving just for myself and my baby, but grieving for this generational kind of illness that has been in my family. And that actually, you know, now that I've moved to a place where I'm getting much better care, much personalized care, and what I would even say at this point, culturally safe care, I now see paying attention to my diet, exercising is healing that generational illness that will not only benefit me, but benefit my children. So it is, you know, birth is powerful, where if it's done correctly, if you're supported by the right people and listened to, you have the power to change you know, the future and heal the past, if you see it as a sacred experience for people, because I tell you, you want to see women really be motivated to change their lives, let them have a baby growing inside of them. You see women change. I mean, overnight, I've never been able to follow a diet in my life. But tell me, you know, it's impacting my baby, and like that changed.
It's true.
I think we found a new product, the pregnancy diet. Put it in Sainsbury's and Asda. You know,
it's really true. And obviously, I know you personally, but I think that you're really kind of getting to the heart here of cultural safety, but also that it's situated within like community, and like you're drawing on that personal historical thing that we mentioned yesterday when it comes to informed decision making, not necessarily so much right now about birth, but about your health. So it's like, you know, they recommend a certain course for you, right? But for you, it was like, I don't actually want to do it that way. And I can relate, because it was similar to me with hypertension. Like every woman in my family has it, at least maternal side. And my grandmother, who probably was the woman I was closest to in my family, died of a stroke. And so, you know, that for me, hearing the kind of pregnancy-induced hypertension at the end of pregnancy, or just the kind of words, it kind of just puts like a fear in me. And the solutions a lot of the time is induction, C-section, and there's no discourse, there's no talking. Thankfully for me, I do have a community around me of like healthcare professionals who are also Black and have similar beliefs to me. And so I go to that community, I draw on their knowledge, because I feel like there's a balance there, and it's culturally informed, and it's sensitive, and it's safe. And it gives me a chance to work out what I'm going to do and what I'm going to do next. So for me, it was, okay, you know, you're high risk. The first pregnancy was high risk because of the actual interventions that happened at the end as a result of going in with raised blood pressure after I had Chinese the night before. But it was straight away, I kind of was given a sweep. I didn't consent to it, but I didn't know what was going on at that time. But I had the cascade of interventions, and then lost lots of blood, had to have blood transfusion, very, very traumatic. Anyways, second pregnancy, there was no blood pressure throughout the pregnancy. When I went into labor, it was raised again, but I was in the hospital environment. Anyways, they didn't really listen to me, and my son was born very quickly in this kind of side room. Fast forward to baby number 3, fine, pregnancy's fine, don't have any kind of blood pressure issues, go into labor, go to the hospital, they say, oh, your blood pressure's a bit up, you have to stay here, we're not letting you in the birth center. Straight away, obviously I feel like threatened. Not only that, but there's a kind of the whole waiting room issue, you know, how they don't see you, they see someone else, and all of that stuff as well. So all of that was going on anyway. I had my son. When I had the baby afterwards, the blood pressure still raised. They kept giving me medication, but it was making me feel really unwell. It was actually making me feel worse. And the readings were all over the place. They actually weren't consistent. And I'm like, I want to get my own machine from home and take my blood pressure. And I just wanted to go home. They were messing around quite a bit, and I just like, I can't take this anymore. I'm going to self-discharge. I self-discharged, went home. The midwife came round, took my blood pressure. It was normal. Make of that what you will. But for me, one of the things that was really important was my backup support. Navigating that, because they weren't just like, oh, do it naturally, do it how you want, or, you know, the things that were quite important to me, but it wasn't a deal breaker. It was like, okay, what are my options? Because I don't feel that I was given all of my options. And that was important to me to kind of manage, you know, the kind of safe delivery of my children. So I think that is really, really important to make sure that like people think about these things in a wider context, and not just like the medical model. Actually, they can complement each other. What can you learn from women who have been in this position before? Because I'm sure, Anna, you're not the first person to have this experience. And I'm sure many people with GD have also got through not following a very specific pathway.
Well, it was really interesting to hear you say all those things, Natasha, but speaking as a midwife who's worked in and out of hospital and also out of the country in some very different spaces, what I can say is that we do need technology sometimes. We do need the support of other practitioners who are experts in different disciplines. But at the end of the day, and particularly now, we need to be able to work with people so that they don't have to be freaked out and fretting about what's going to happen next. They've left me here. I'm having all these, it really does not need to happen at all.
That's what I'm saying, Elsie. I feel like there wasn't like a coming together. There wasn't like an acknowledgement of like, oh, who is your support system? What is your support system? And building on that. That's something I think needs to be done better today.
Much of that can actually be done in the antenatal period, and that is where I put a lot of my effort now, to help women to understand the different pathways, to understand the importance of their voice and what the law says. And if necessary, I think there was somebody asking for some support. I think it might have been a doula asking for some support for a woman. She was supporting a woman in hospital online, so to speak, or on the phone or something like that. We shouldn't have to be fighting at that time for our voices to be heard, because that actually just messes up the whole hormonal process and shoves birth into another space of anxiety, raising of adrenaline, and the dumbing down of the oxytocin, which will help the birth to go well. I don't know. I just find it sometimes it seems like it's being done on purpose. And I don't know what else to say about that, because I cannot understand why it is that professionals who should understand what birth is about, the physiology of birth, and what bringing in things that cause anxiety does to birth.
Right.
Really, I don't.
Sometimes when I hear of women who perhaps have care that's outside of guidelines, and you hear, I guess, and I have this, I had this shock because, again, with my first pregnancy, everything was low risk, straightforward. I didn't have to think about anything. And then with this pregnancy, you get this label of high risk. And, of course, you freak out. And I talk to all my doula friends and my midwife friends, and they say, well, I know someone who, had diabetes and they were on insulin and they gave birth at home. And, and then the next thing that everyone says is, but she had to fight for it. She did have to fight for it, but she got what she wanted. And I just think women shouldn't have to fight for it. It shouldn't, you shouldn't, this is not a time where you want to be fighting. And I can see, I think as someone mentioned earlier, where women will just go on the course that's set out for them by other people, because you just lose the energy. You lose the strength to just fight at every turn. I think if women are valued and you really see the person sitting across from you as someone who's equal, someone who's an expert in their own personal experience and lived experience, and you will value what they say and really talk through the options with them. So it doesn't have to be a fight.
And as one woman said to me some time ago, she said, we hired private midwives because I didn't want to put on my bitch face. I thought, right.
Well, yeah.
I think Ori touched on it yesterday, the kind of paternalistic elements of like care and how it like really puts people off. And I think that's why I think birth partners are just so important. And but your birth partner isn't necessarily the person that's just like at your birth. It's also like the people that make up like who you debrief with after your appointment, or who you're getting a second opinion from. And so that's why I think that this kind of like community model should be, it's not so much like a community model, but the idea of like your community, like who makes up your community, who makes up your social circle, should be taken into account with care, because it's really important, you know, to when that kind of thing is put to you, the fear, you know, like you can't survive a pregnancy with constant fear. You can't survive a pregnancy with the label risk, high risk, death, like that all of those create, you know, like a feeling in you that's just going to make you do the two extreme, like being completely petrified and yield yourself, or have so much fight in you that is harmful to you. And so go on, Elsie.
No, I was just going to say, I mean, as you're saying that, I just want to touch on the morbidity, which for me is a much bigger problem than the mortality, believe me, because you're talking about the fight and the fear and all of those things. And this is one of the reasons I believe that women should never have to fight, never, certainly in labor, pregnancy and labor. But we now have the research, we've had it for some time, that women who've experienced mental health issues when they're pregnant, anxiety, depression, that actually manifests itself somewhere down the line in the child who was in the womb at that time. So a lot of the mental health issues that are happening now, we can ascribe to, in the young people, we can ascribe to some of this trauma, and God knows what's going to happen to the children who have been embroiled in all this situation during the pandemic times, you know. So I think we have to manage those sorts of situations. I mean, and as I was saying to the women, yes, you will get anxious, yes, you'll be scared and whatever else, but actually you just have to work it through so it actually comes out of your body.
Yeah, discharging that's so important. And that's why I think like finding groups or creating the support network, talking to friends, if you can, like tell a friend what's going on, tell somebody what's going on. But even just us and other groups having these conversations online can help people to kind of feel their way about. It makes them not feel alone. It lets them know that there are people thinking about them and thinking about what they're going through and trying to find solutions. A lot of time people think these conversations are just for healthcare professionals or just for researchers, but actually it's nice to know that there's someone thinking about how maternity care can be better for me, or you know, coming up with some suggestions that I can think about, you know, that I would like to see in my maternity service as well.
And then as people of African descent, we deal with these things in very different ways. So, you know, as myself personally, you know, I'm into, as I was saying to you the other day, dancing, drumming, music, singing. These are things that are so important in my culture. And these are some of the ways that I release my anxieties, my tensions. I deal with difficult situations. And I'm not into CBT and stuff like that for things that are really getting to me. So I'm different to lady next door who might be from Scandinavia, or, you know, they may do it in a different way. And what we don't have are those support systems that we need to develop, but we have to understand we're not getting the research money or the funding to develop these things. Somebody else is doing it on our behalf. And I swear to you, these are the things that are just going to continue to be perpetrated as we go on down the line.
Elsie, I'd like to mention what you just said there about the drumming, and it just reminded me of, you know, the kind of traditional midwifery practices of Africa. Do you know what I mean? Like when we're talking about physiological birth, you know, the practices that have been lost, you know, we had all the drumming, the dancing, the, you know, giving, but it was a whole experience, but it was part of the wider culture. Birth was not separate to that. You know, even the initiation of before a boy could become a man, there used to be a ceremony, like it from literally cradle to the grave. And we don't have that. You know, we don't have that. Everything is in silence. You know, we're doing different things here, we're doing different things there, and we're trying to, it's like a kind of a patchwork type rug or a blanket that we've got. And I think some of that is also what's adding to the trauma, because we're trying to birth, we're going to birth, we're being told we need to birth in this way. Then even when we're trying to get joy, we're told we need to get joy in this way. And when we're trying to just be, we're being this way. When we're just anything, if we're being told in all these different ways.
You're too loud.
You're too loud, you're too this, you're too that. And it's confusing, and it even compounds on the mental health. Whereas back in the day, you know, our great mothers, when they were in the village and so forth, you know, from the moment a woman announced that she was pregnant, or, you know, even before, when a woman had her first period, whatever it was, there was different celebrations and, you know, wise women and so forth within the environment. So everything, nothing, a physical act of having your period was not done in silence, was not done in isolation, with how the elders would come and then speak with you and so forth. So nothing was done on its own. When you gave birth, again, it wasn't done on its own. Like you went to go and give birth, you had the other women that would come and support and so forth. So there was all these cultural underpinnings, but again, as I said before, here in the UK or in the Western world, we're Black, we're not like that in Africa. It's the same with our cultural, we're on our own like that. So we need to start thinking of what are these practices, these peer-to-peer support groups and so forth that we've got. What can we be doing to stimulate some sort of well-rounded or all-rounded experiences for our being? And our being is not just, we don't just exist because we are women and we give birth, or for those that choose to give birth, but we exist to have joy and be able to have a life that is unapologetic in the world, you know, for the short time that we are here. And that encompasses everything, how we, you know, from our children going to school, the way what we can show up in the workplaces is authentic. And I think that has been lost. And I think if we get to that, as you said, physiology, you know the word, that for birth. Once we look at that experience in totality, in the whole of our being, in terms of how we are in the world, I think then that will help to really reduce some of the trauma that we're experiencing.
I think Agnes,
one by one, Agnes. You know,
yeah.
It's and the greatest thing, you know, like I said about the policy. England has been fantastic for the policies that it has created. And just as a sideline, Anna, guidelines are guidelines, right? They are guidelines. They are not rules. And if you follow a guideline as a midwife or a doctor and you get hold up, you can't say, oh, I followed the guideline. You gotta give a reason for following or not following guidelines. So they're just guidance to help you. But the primary person is the pregnant person in front of you and how to work with them. So yeah, but so we have these policies, Anna, to help us really and truly. So if you look in the Better Birth, which is the extant maternity policy, you will see in there these very different models which have been the recommendation. I do have a problem with Better Birth in terms of cultural cultural safety, right? Which I won't talk about now, but I do have a problem with it. But within the recommendations, there is an allowance for us to begin to do something about these issues that we're talking about, to return to woman-centered care. And if women are beginning to say, I choose, using the Montgomery judgment, I choose, this is what I need, I am making this decision based on whatever it is, then we should be able to create spaces starting where we have to start small, because we can't be biting this big elephant, you know, with one.
By itself, yeah.
Start small. But we do have a policy recommendation. There's a policy in there and models of care that will help us.
But Elsie, who's telling women that there is a Montgomery judgment? Who's telling women that they can accept their care? Yeah, no, I know, but I think in general, because how I see it is usually when a woman is pregnant, it's this expectation that professionals always know best, right? And you can't really assert yourself. So
anybody who does that now is really taking their pin in their hands, to be honest. Really, ever since Montgomery, you know, put herself, how many years it took her to get this judgment out.
Yeah, I think I hear you, Agnes, with this, and like there is like we need to get that Montgomery message out, you know, and I think give people the tools to navigate care. And for me, a lot of the support I've given people looks like pulling and pushing. Like it's not always, they can't always just push through and say this is my right. Sometimes it's about kind of not even saying anything. It's like nodding gracefully, leaving, knowing what you're going to do. You don't even need to say anything. You just need to know what is the evidence and what you're going to do, and you kind of have to so you don't have to stress.
Yeah.
What happens is that you can live kind of disembodied as a Black woman. You know, if you have stress at work, have stress at the doctors, and maybe at home, right? There becomes a point where you're trying to disconnect from that, because you're trying to disconnect from the effects, the tiredness. And so you ignore the tiredness, so you push through. For some people, it might look like just overworking and chronic fatigue. It could come up as fibromyalgia or some other condition. For some people, they'll live off of sugar, you know, and then end up with perhaps diabetes or hypertension or something like that. There's a way in which we are forced to navigate the world. And I think that, going back to what you were saying before, Agnes, that we need to be able to have a moment to be present within our bodies. I think that I've been to beautiful birth class with Anna that she did a few months ago. And it really, what was wonderful about it is she really made us all, the first exercise was to have that, be present within the body. And she asked a question that I had never even thought about through all 3 pregnancies. I'm like, I wish I had thought about that. And it was a simple question. It was like, have you connected with your baby, or how have you connected with your baby? And it's just a taken for granted, you know, thing. It's not to say I don't think I did it at all, but I didn't actually just think that, like, what have I done?
It wasn't conscious. It wasn't conscious.
What have I done within, you know, my pregnant body? But actually, Anna, I do that now, like every day now. I say, like, hey, what's your body telling me today? And that sometimes means disappointing people. Say, I'm not coming, like I'm not leaving my house. I'll call you back later, I'm not answering my phone. Or just, you know, avoiding certain dynamics or contentions, maybe leaving certain jobs or roles. So I think that actually we need to have a movement. I think there is a movement where we need to be really present in our bodies. And that's a way that we can undermine some of the things that are happening with regards to health. But certainly it needs to be something encouraged for pregnancy, as well as creating that support as well. And I thought you was going to say something, Yelena.
No.
Right, I don't know if there's any further comments or any questions. Actually, I think we've got some questions. Let's have a look.
Before we get into questions, I just want to say that I found this really, really useful as a host and then also as an attendee with my attendee hat. I've learned so much from you both, and just food for thought, if that makes sense. I feel like the conversation that we've had here, I can definitely see how that will make me question things or ask other questions in different settings. So I just want to say thank you anyway, just before we get on to the other section now.
Thank you. And yeah, just to kind of round up, I think like some really important points have been made about this kind of looking at cultural safety from like the system position. But I really appreciate some of the personal experiences that have been shared today as well. And I hope that, like yourself, Agnes, other people can also think about and reflect on and like their own well-being as well, and their own kind of autonomy. So the question we have is from Mary Newman, and it says, Anna, it's directed to you. So it says, it's great to be back. It sounds like you don't think the term cultural competence is helpful, Anna. I understand your distinction between cultural safety and cultural competence. I noticed that cultural competency is widely used in Australia. For example, the University of Sydney has National Centre for Cultural Competence. Are the terms used differently in different parts of the globe, perhaps? Do you think there is a movement away from cultural competency in language towards cultural safety?
So thank you, Mary, for your question. And I'm not positioning myself as the authority on, cultural safety or cultural, all of these terms. But from my understanding, I think in literature, there is a move away from terms like cultural competency, cultural awareness, and replacing it with cultural safety. Perhaps, I don't know, 30, 40 years from now, we'll be moving onto another concept building on that. I think what we've seen is this, as we learn more, know more, reflect more, we build on these concepts. And perhaps at one point in time, cultural competency is what was needed. But someone came along and said, actually, we can do better than this, and added something else. So it's interesting because a lot of what I've learned about cultural safety has been from a fantastic training course that was actually based in Australia.
Yeah.
And, you see, from my understanding of it, cultural competency sort of sits in the camp where it, and they didn't use the term cultural competency to describe it, but just how we tend to approach these kind of cultural awareness, diversity, kind of inclusion initiatives as something that centers whiteness and others everything else. It's not white. So white is a standard and everything else is kind of a deviation of white. And you can become competent in someone's culture. It's kind of like a tick box exercise. It becomes something that people of color have to take on. And I think cultural safety and as Elsie said, has really requires us to think about power dynamics. It requires us to turn the focus also on ourselves and ask ourselves, okay, what shapes my worldview? What's my, limitations here? What do I need to learn? And really be humble. I mean, even in America, I think cultural safety is sometimes used, but also cultural humility is another concept that was developed by Black nurses, I think. So, there are lots of different terms out there, but I think the foundation of it is not just about learning about the other and getting those tick boxes right. So that you can, it just kind of like makes people tick boxes rather than seeing it as an energy that flows about who's in front of you, who you are, and engaging with people on a human level, rather than something that's, something that's clinical and tick boxy. That's what I get from it.
And can I just add to that for you, Mary? It's really about developing, certainly in healthcare and maternity care, according to Iri Hapati and her thesis, it's about developing therapeutic relationships, really.
Thank you. Elsie, I have a question for you. So I know you've been a midwife for a very long time. Could you explain a little bit about your practice with cultural safety? So how do you do it? What does it look like for you?
God, that's really,
We've
well,
got 3
basically
minutes,
it's
so.
about listening to, it's really about listening to people, you know, and their needs, their values, which they articulate. You cannot possibly just do that in one visit. In the 10 antenatal visits that a woman is afforded as a first-time mom in the system, or the way that maternity care is given. So continuity of care is perhaps the benchmark for that concept of cultural safety. I don't think we can transfer it from one midwife or one caregiver to the next, to the next, to the next. We're talking about continuity of notes or something like that, but certainly not developing a therapeutic relationship in the maternity care pathway. Listening, working with someone. I mean, some people will have some very strange, to me, ways of wanting to do things, but it's really about working with a person in terms of your understanding, or certainly my understanding, of what good maternity care, quality maternity care looks like, and paying attention, helping people to develop ways to support themselves. Because really, at the end of the day, I'm not there to enforce my thing on people. It's actually to helping them to find their way through whatever is going on. So it may mean that a woman with diabetes has to be referred to a physician for support. She may also need to engage with other people. I mean, I'm using that because of Anna's declaration this evening. She may need other people in terms of her diet and physio and whatever else. But these things are really, really important. But it's actually there to be there for her, to stand behind her, to help her to voice out, or to voice out for her when she can't. That's basically it, really. And having respect and regard for this new life that she's growing and birthing, and then will have to nurture, is really helping her to do that. And not in a way that puts me at the front, but actually I'm there beside her doing this journey, giving her the wealth of my experience, my knowledge, my skills, and everything else, so that at the end of the day, she will be saying something like, I did it, not, oh, Elsie, you helped me to do it. It's not about us at all. At all. It's really about this person who has come for support. And I have to say, you know, it's not just in our we have a little practice that we're trying to get up and running inside the NHS to work in this way. And I'm not the only person who feels like that. Most of us are Black women. Leslie Page is our patron, and she's about humanizing birth. We're not all Black. We have a white PMA, and we're working to try and get this up and running, because, you know, little, we will get there. We can't throw our hands up and sort of say, well, you know, we give up.
Thank you, Elsie. Thank you, Elsie. Thank you, Anna. Thank you, Agnes. It's been such a great conversation today. I hope that all of our attendees have enjoyed it, have got something to take away from it. I know Marielle has a question about the recordings. Yes, they will be made available. We're just thinking about the best platform that, you know, to put them on, so that they're just, you know, accessible basically, and there for when, you know, people need them. So if you follow our social media pages, or you can send me an email, then you will be aware when they're all made live. So thank you everybody for coming. You are free to go now, and stay tuned for our next project, which we're not sure what it's going to be yet, but there'll be more.
Yay, thank you, and well done. I just want to extend a big well done to Natasha. I remember when this idea came into your head, it was a few months ago, And since then, you've done a whole report,
yes,
and a 3-day webinar, in such a short period of time. So I would just like to just extend a big well done. Amazing. This is, you can't. I know I've said this on the phone, Chair. I know you're probably thinking, Agnes, okay, be quiet now, quiet. But to achieve what you've achieved in such a short period of time is not something that can be dismissed. So just from one sister to another, well done, girl.
Well done.
But that's what we do, isn't it? We support each other. So yeah, thanks for asking me to come on and share. It's been great, actually, great.
No, it's been an honor working with you, not just like on the webinar, but behind the scenes. It's been so lovely, and I love and appreciate you also. Thank you so much.
Thank you. It's always a pleasure.
All the best, Anna.
All right, then, bye.
Bye.
Bye.